Hello, everyone. This is Matthew Rupp from Walden University Center for Faculty Excellence. Today, Walden University Center for Social Change and Real-World Solutions to Real-World Problems series presents a global response to and challenges of the novel coronavirus and COVID-19. The presentation recording and a copy of the slide deck will be available on the Center for Social Change website, which we will discuss further at the end of this presentation. Now I'd like to show you some of the features of the Zoom room. You will notice in the bottom left-hand corner, there is a button that says Audio Settings. If you click that button, a window will pop up where you can adjust your speakers. You may notice that, that all the microphones are muted today. At the bottom of your screen, you have some options down there. The chat feature has been disabled since we have a large audience. However, you will notice that closed captioning is available today, and also our Q&A section is available today. So if you do have any questions throughout the presentation, please feel free to click that Q&A button and you can ask your answers or ask your questions. You have two options. One is you can ask a question using your name and having your name show. The other is to ask questions anonymously, which you can see. You can check on that Send Anonymously button there. Once you've typed in your question, just click the send button and that question will come to our moderators. Some of the questions we're gonna answer as we go along, and then some of them we're gonna wait. We do have a session at the end set up for Q&A. At the top of your screen is a button that says View Options. This brings down a little window where you can see the zoom ratio or the window ratio that you can change. You can also exit full screen. This is very helpful if sometimes the window takes up the full screen and you want to minimize that. There's also a button in the bottom right-hand corner that says Leave Meeting. So if at any time during this presentation you need to exit the room, please click the Leave Meeting button. We'd like to go ahead and introduce our moderators today. So today we have three moderators. We have Dr. Savitra Dixon-Saxon, who is the Vice Provost for the College of Social and Behavioral Sciences, and she is our executive sponsor. We also have Dr. William Schultz, the Director of Walden Center for Social Change, who is also an executive sponsor. And then Dr. Tamika Luckett, our Director of Continuing Education for Nursing. And now what I'm going to do is I'm going to hand this presentation over to Savitra, who's going to introduce today's panelists.
Thank you so much, Matt. And I'm actually going to pass things over to Bill in a second for him to complete introductions. But I'd like to welcome everyone to this webinar and to this very important session. And I'd like to just tell you a little bit about our series, Real World Solutions to Real World Problems. In 2018, we made a decision that we would start a webinar series or in conferences, a series of platforms for discussions about the most critical, complex, vexing issues facing us, and use our community of researchers and scholars and their expertise to address some of these issues. Last spring of 2019, we had an opportunity to engage our community around water scarcity and food insecurity. And today we wanted to work with our community of experts to address COVID-19, the coronavirus and COVID-19. So we're really excited about today, and we're excited about interest, and we're hopeful that throughout the session today, you'll get some of the answers you may have to these questions for yourself and for your community. So now I'm going to turn things over to my colleague, Bill Schultz, Dr. Bill Schultz, Director of the Center for Social Change.
Thanks, Savitra. Thanks so much. And thanks everyone for attending. This is really an important topic, a timely topic. We see in the news pretty much 24/7 now updates on what's happening with respect to the novel coronavirus and COVID-19. We felt it was important, since we were being asked actually by the CDC and others, for Walden University to have some communication out that's based in expertise and knowledge of epidemiology and medicine, public health, trauma response and crisis response and communications. So we put together a panel that I think you'll find very interesting, have a lot of interesting things to say and help us learn more. our goal today really is to help all of us leave today's session a bit more informed, a bit more, if you will, information literate about this particular topic, so we know a bit more how to process what we're seeing and hearing in the news. We're going to start with Dr. Amy Ferraro, who's going to talk a little bit about health and behavioral sciences. We'll then talk, the order is a little bit backwards here. We'll hear from Dr. Hiba Tawfiq, who's a physician in public health. We'll talk about some of the medical issues with this particular disease. Jennifer Perkins, Dr. Perkins will talk about this from a public health and human services perspective. Cliff Bridges is an expert in corporate sustainability and crisis communication. And Shelley Fries will be talking with us about crisis response and psychology. So we have a wide range of topics that are being covered, and we will, beginning to, Savitra, Tamika and I will be monitoring your questions live. If we find that it's appropriate to engage with a speaker during their segment of the review, we'll do so. Otherwise, we're going to hold questions off. Our goal is to be asking questions about an hour from now. So we've got a lot of material to share with you, and we're going to get started with Dr. Amy Ferraro.
Thanks very much, Bill. Do we need to go forward with announcements first, or you want me to get started on the slides?
You know, I jumped because I'm so excited to hear from you guys. There are a couple announcements we have to go through. So for those that are here in nursing, public health, health education, this webinar is potentially, you can earn continuing education credits from it. So this is an announcement, a disclosure of that information for you. There are no financial relationships currently or within 12 months related to any of our panelists. We're accredited to be able to give you continuing education credits for this. This is the information you'll need to know. We'll give you some more information as we go. Also a disclaimer to make relative to the continuing education, so we'll go to the next slide. This is all intended for your education as individuals as well as public health and education professionals. We encourage you to consult other sources, government sources, your organizational sources, and that no single reference can take the place of being trained or education and experience. Next slide, please. Good. So now, Dr. Ferraro, thank you.
Thanks so much. Bill and Savitra, I really appreciate the opportunity to speak on this very timely and important topic. I will be presenting today a discussion of the population view of COVID-19, and this is based on my experience doing outbreak investigations and infectious disease epidemiology. I'm going to turn off my video because I'm calling in from Peru and the internet connection isn't always stable, and we'll focus on these slides today. So next slide, please. Just to get started, we need to be clear that there's a lot of acronyms being thrown around, and the first important one to know about is what is COVID-19 versus SARS-CoV-2. So the novel coronavirus is SARS-CoV-2. It's a new virus itself, and that's what causes COVID-19, or this disease that we know of that has a range of symptoms, and we'll be talking more about this today. We know that SARS-CoV virus has an animal source, so it's labeled as a zoonotic disease. Go ahead with the next slide, please. So what is coronavirus? It's a large group of viruses that consist of a core of genetic material and surrounding an envelope with protein spikes. And that gives it the appearance of a crown. And the Latin word for crown is corona, so that's where the name comes from. There's several different types of coronavirus, and they cause respiratory and gastrointestinal symptoms. In this outbreak, we're more knowledgeable about these common cold and pneumonia type symptoms being presented. Some of these coronaviruses cause more severe symptoms. Some of the more famous outbreaks we've seen was the severe acute respiratory syndrome coronavirus in China in 2003, the Middle East respiratory syndrome coronavirus in Saudi Arabia in 2012, and then this one now is called COVID-19, and because it started in China in 2019. Next slide, please. So how does COVID-19 compare to these other two coronavirus diseases? You can see in these graphs, we have the confirmed cases and deaths reported for all three of the diseases. And in COVID-19, shown in red, has already outpaced SARS and MERS with over 10 times the number of confirmed cases and triple the number of deaths. Next slide, please. So this novel coronavirus was first identified at the end of 2019 in a cluster of pneumonia cases who had exposure to a seafood and live animal market in Wuhan City, Hubei province of China. So the outbreak initially started through animal to person transmission. That's that zoonotic disease. Throughout January and February, COVID-19 spread through person-to-person transmission among family members and healthcare workers, and that was largely throughout China. On January 30th, the World Health Organization declared the outbreak a public health emergency of international concern. And through February, the virus continued to spread through person-to-person transmission through more than 30 countries. Now, over the past few days, we've seen it spread even farther, and it's in over 70 countries. And we've seen reports of community spread, which means that some people who have been infected are not sure where or how they became infected. So today was the first day that China reported fewer diagnoses and deaths compared to the rest of the world. So the World Health Organization is hesitant to use the word pandemic, but at this point, the fact that this disease is spreading so widely and it continues to spread quickly, it's likely that this pandemic label is imminent and we'll be using it soon. Next slide, please. This is a map provided by the World Health Organization. You can go to their website and see daily an epidemiological report that shows where cases of COVID-19 have been reported. As of yesterday, the World Health Organization reported 93,123 confirmed cases, with over 80,000 of those being reported in mainland China. There are about 3,200 deaths, and almost 3,000 of those have also occurred in China. So the outbreak has largely been confined within China, but as you've heard through the news lately, it's spreading around the world. And in this map, you can see that most of the cases are being reported in the Northern Hemisphere. Africa and South America are just beginning to see new cases. Next slide, please. Now, the COVID-19 outbreak is definitely concerning because of the rapid spread and just within China and around the world over a matter of a few months. However, there's a few issues that we should consider when we interpret the data provided by China. So early on in the outbreak, there were some concerns that Chinese officials were underreporting COVID-19 cases. Initially, they were using a case definition where they reported only people that had pneumonia and tested positive for the virus using a laboratory test. But on February 12th, this is the spike you see in these two graphs here, the Chinese National Health Commission expanded their case definition to include clinically diagnosed cases, and that was using CT lung scans. They claim that this gave doctors a choice to treat patients without lab tests and allowed them to more quickly administer treatments. However, this change resulted in a drastic spike of over 15,000 confirmed cases and over 200 new deaths. It's kind of shocking when that happened. A week later, the Chinese officials returned to their original case definition, so there was then a sharp decrease in cases reported. So it's actually quite common for epidemiologists and medical professionals to change a case definition as we learn more about a disease. But these drastic changes definitely has caused some confusion, and it's made it difficult for us to fully understand the extent of the COVID-19 problem in China. Next slide, please. There's another important concept to consider, and we call it the iceberg phenomenon of disease. And it's a concept that illustrates the progress of a disease from its subclinical stages to overt or more apparent disease state. So the floating tip of an iceberg represents what physicians see in the hospital or a clinic. Those are the cases that are presenting and we're seeing reported in most of our epidemiological reports. But there's a submerged portion of the iceberg that represents this hidden mass of disease. Those would be subclinical cases, carriers of COVID-19, anybody who's undiagnosed or even asymptomatic cases. And the reality is we still don't know much about this hidden mass of the iceberg for COVID-19. Number one, because China hasn't been reporting subclinical and asymptomatic cases, and two, because maybe those people aren't presenting for healthcare services. So there's still a lot we need to learn. Yes.
So what we're seeing in the United States now is I don't know how to characterize it as rapid, but we're definitely seeing an increase in cases. In part, I think I'm seeing, and this is the question I have, is it because we're beginning to really do much more systemic measurement and testing? Right?
Yes, it could be two things. It would be, number one, people are presenting, the more severe cases will be presenting themselves for care. And then yes, that they're being tested and there's more widespread testing happening. I mean, a couple of weeks ago, I think there was some concern that there were no test kits available, and now there's enough to do 15,000 tests a day in a lot of laboratories. So it's a double-edged sword. It's the ability to identify those cases, plus we need people to actually present and show up to be seen.
Thanks.
Sure. Okay, next slide, please. So it's totally understandable why when we see all these cases, the numbers go up every day, the deaths are, sound pretty significant, this fatality rate, it's 2 to 3%. What does this mean? It's important to keep things in perspective because it's easy to let fear become more dangerous than the virus itself. So yes, COVID-19 appears to be highly infectious and it's spreading rapidly. It's estimated that one person can infect 2 to 3 others, and that's what we call the reproduction rate in epidemiology. However, to date, the majority of cases have been diagnosed and reported exposure in one province in China. It's like 83 to 85% of people that are currently reported come from Wuhan or had exposure in Wuhan. So we have over 50,000 cases have recovered. We don't often hear that number reported. If you do the math, that means 43,000 cases are currently living with COVID-19, but 50 more have actually recovered. Every single death has occurred in a critical case, and 80% of all cases have been mild, and among those mild cases, no one has died. The majority of deaths have occurred in cases over the age of 50. And in fact, it's a curious thing about COVID-19. There appears to be no deaths among children between the ages of 0 and 9. There have been a few cases reported, but none of those children have died. The death rate appears to increase with age. It ranges from 0.2% among cases between the ages of 10 to 39, and it increases up to 14.8% among cases over 80. In addition, the death rate is higher among cases with certain pre-existing conditions. There was a study of 72,000 cases in China that showed a death rate of 10% for cases with cardiovascular disease, 7% with diabetes, and 5% with cancer. But the death rate for anyone with no pre-existing conditions was less than 1%. So in other words, this disease appears to be more fatal among the elderly and immune compromised. However, when we consider that iceberg concept of disease, the fact that no one's counting asymptomatic cases, and maybe not all of the asymptomatic cases are showing up for care, the overall death rate may be less than that 2 to 3% fatality rate we often hear reported. And yesterday, the WHO director reported a 3.4% death rate outside of China. But again, we need to interpret these kinds of statistics with caution. Next slide.
Yeah, so Amy, could I ask about that very issue? Because I think we discussed this yesterday a little bit. It seems to be, from what I'm hearing, that we really won't know whether this is 1% or 0.5% or 3%, perhaps even for a couple of years, right?
Correct.
All these early estimates are really blunt, and that it can feed. This is an area of uncertainty they keep telling us to be careful of. How would you respond to questions that are asked quite a bit about, well, the flu kills so many more people, and this isn't such a big deal, this COVID-19 stuff. How can we let people understand better the comparison to the flu?
This is good. So if you could move to the next slide, that's actually the next topic, because it does relate heavily to this. And we often use a comparison to other diseases that we already know a lot about. Influenza has been around a long time. It's been studied widely. So we have a better understanding of, its seasonality and how many people typically get it, present for hospitalizations versus how many die. And we don't know all of that yet for the coronavirus because it's brand new. However, it's difficult to compare apples and oranges. Coronavirus is different than influenza. We don't have community level immunity to this yet because it's brand new. There is no vaccine, and its characteristics are unique. So we need to treat it still with a new set of eyes and an understanding that we're going to learn more over time as more data is collected. What you were talking about, though, influenza, yes, is compared, I think, as a means for people need to realize that this is already circulating. It's another respiratory illness that's very contagious and causes thousands of deaths a year. Even billions of people have already been diagnosed with influenza just this season in the United States. And there's there's estimates of 16 to 41,000 flu deaths. This slide here demonstrates why do we have such a wide range of numbers? Well, this is accounting for that iceberg concept of disease. We know for sure 29,000 have presented or have flu illness, but we suspect there's been others that haven't tested positive or they haven't gone to the doctors and they treated themselves. And so we often give ranges and numbers so that we can fully understand how to prepare for this, how to make sure healthcare systems have enough resources to help if these cases end up presenting to the hospital. So I think another point here that's important to consider is that seasonal flu can't be stopped. It's already endemic around the world, but we still have a chance to limit the number of the COVID-19 spread. And that's by implementing public health measures that have already shown to reduce viral spread. So I hope that answers your question. Right.
So the goal really is now and in the future to keep this from becoming another widespread flu-like thing that occurs every year.
Correct. And another one that's often brought up is the SARS virus from early 2000 from China. That still circulates around. It's just not as common. So it was a big boom of cases in 2003, but then after that, it sort of just ends up circulating at a smaller level around the world, and it becomes part of like this ecosystem of respiratory diseases that go around. So yeah, it's kind of it's good to keep perspective in that. Yes, we can compare, but we also need to remind ourselves that there's something different that can be done for this disease.
So there was an interesting question that came in since it's related to this slide. For comparison purposes, do we know the submerged part of the seasonal flu? That is to say, how much more do we understand about the flu in that hidden region of the iceberg than we might know for COVID-19?
Yeah, we certainly know more than COVID-19, and because just so many years they've been monitoring and tracking influenza virus. However, I think still fully that it's very difficult to identify asymptomatic cases and it changes every year. So we might know that this year, this is the numbers that are being presented. But if you look back last year, it was different, and it could have been sort of a light season. And so maybe there weren't as many people that even showed up to the hospital. And so, right. But there were a lot more carriers running around and just didn't get as sick. I've also heard another comparison. I think it was the 1957 flu outbreak that was very quote unquote bad and had a lot more deaths than usual. So yeah, again, these are all like estimates and we can model as much as possible, but it's a very nebulous number because there's so many factors involved.
It's just the risk we take every year living is these viruses attached to us.
Yes. Yep. Okay, I think I have one more slide in my presentation, and it relates to how are governments and countries going about trying to control and contain the spread of COVID-19. Nobody's using this term pandemic yet, but we all kind of know that it's spread around the world and it's there. So far, countries like China and Italy have attempted to slow down how fast COVID-19 spreads through their community, through containment methods. That would be the left hand of this slide. This include mass quarantine and isolation, and mass quarantine isn't very often used in public health. It's some have used this term as a draconian device. I don't think necessarily it's so bad. That China has maybe been quite successful in slowing the spread of this disease by being a little more extreme in their containment of the movement of their people. So they've also been pretty successful using contact tracing, which is identification of persons who have come in contact with someone who has already been identified as a COVID-19 case. But as this disease continues to spread around the world and hits pandemic levels, containment methods are no longer going to work, and it might even be counterproductive. People might become afraid of going and presenting to the doctor because they're going to be discriminated against, or they don't want to have quarantines. They just keep going about their regular life. And we couldn't have the entire world shut down with nobody producing foods, transporting goods. We see the impact on the economy with the stock market, has been hit pretty hard. And healthcare systems and emergency services just can't maintain high levels of vigilance in this containment mode. So we have to move into mitigation. And that becomes important because it can help reduce the intensity of the outbreak. It might not get rid of it entirely. That moves from this big purple curve down to the dashed smaller one. And it also reduces strain on the health system and the economic well-being and social well-being of society. So mitigation efforts include individual measures like frequent hand washing, we hear this a lot, and collective measures like social distancing. You hear more about cancellation of mass events and adopting remote work and education practices wherever possible. I think my colleagues will provide more detail about these mitigation measures and how you can prevent COVID-19 infection in your home and community. Thanks
Indeed.
for joining me.
One last question,
Sure.
Amy, and
Yes.
I don't know if this goes to containment or mitigation or both, but apparently China is able to test some 14,000 people per day. Are we learning from China? How are they able to scale up the testing so much when it appears that, at least in the United States so far, our scalability has been low?
Yes, most definitely. In fact, early on, that's why Chinese officials moved away from that case definition, including a test, because it was taking too long to get the results. And there were some hospitals that maybe didn't have enough testing facilities or test kits to manage all the new cases. So there was a lot of research, and some companies came up with faster tests. There's several different kinds of tests. Some test something like the nucleic acids, others test an antibody. And apparently a Chinese university came up with a test where you could get results within 15 minutes. I don't know if you've seen on TV, there's now testing is happening just from within your car, drive-through testing. So you don't even have to go into the hospital. And I believe that's out of South Korea. And maybe England, they're doing that. So we're all learning from the sort of the first wave of this outbreak went through China, and we can learn and try to take the best of their methods as any other, so now the United States will be a second or even a third wave, because really the second wave was probably countries like Japan and South Korea and Italy and Iran. And now the United States and wherever, France maybe and some other European countries are going to start to see an increase in cases. And they're getting quick and finding out ways to keep cases at home and self-isolate, as opposed to trying to build a whole new hospital to have them all come in and be served in one location together.
Thanks.
Sure.
Great. So let's talk a little bit more then about the disease. And Dr. Hipotrofic, would you take it for us?
Hello, everybody, and thank you so much for attending. Thank you, Bill, for introducing me. Despite the concern, despite that we're here to discuss something that's very concerning, it is a pleasure to be with you here. Dr. Ferraro gave us a wonderful introduction on the population statistics and what this disease looks like. And I'm going to talk a little bit about the medical aspect of the disease and some of the important public health implications. Now, turn my camera off so we can focus on our slides. But generally speaking, there's a lot that we do know. There's a lot that we still don't know. And hopefully we'll go through that today and try to separate fact from fiction. So, first I'd like to share with you a very interesting slide. Next slide, please. And this is a fabulous resource, actually, that I do hope you take the time to visit. It is, you will have access to this deck of slides at the Center for Social Change. And this is it's a short video, it's not too long, but it is extremely helpful. Has a lot of information about the disease, the symptoms, the diagnosis, the treatment, and the prevention. And if you go to the Walden University's Center for Social Change, you'll be able to access it. I do highly recommend that you watch this. It's very informative, very educational, and you can also use it to educate others about this disease as well. Next slide, please. So what is COVID-19? COVID-19 is the name given to the disease itself, and the causative agent is referred to as SARS coronavirus type 2, as Dr. Ferraro mentioned. So COVID-19 is the name of the disease itself. Now, to other coronavirus infections, this virus essentially affects the respiratory system. Most frequent presentation is going to be fever and cough, more of a dry cough. And then obviously for any of us who've experienced influenza or even a severe cold, there's that feeling of fatigue, muscle ache, exhaustion, what we refer to as myalgia. Now, the final major symptom that's used to diagnose this disease, as reported by the World Health Organization and the CDC and the other reports that we've seen, is shortness of breath or difficulty breathing. However, it's really important that we realize that shortness of breath is an indication that the virus has already affected the lungs, as opposed to just the upper respiratory airways. So not all patients are going to present with this symptom. On average, most patients are seen to experience this somewhere maybe 5 to 6 days after the onset of symptoms. So it's really important that we don't wait until shortness of breath sets in to start suspecting the disease.
So Hiba, there's a question here about the method of spread, which bodily fluids can spread the infection. What do we know if somebody, even if somebody's asymptomatic, what do we know about how they're shedding the virus and making it available to others?
Well, that is a very, very important question. It's an excellent question. And now COVID-19 is spread primarily via respiratory droplets. And that means little blobs of liquid that are released when someone coughs, sneezes, or talks. And the virus contained in these droplets can infect people by entering through either the eyes, the nose, or the mouth. And that usually happens when the virus either lands directly on somebody's face or when the virus is transferred to an individual's face by people touching their face with contaminated hands. Now, we need to keep in mind that respiratory droplets are too heavy to remain suspended in the air. So direct transmission, like just one person-to-person transmission, only usually happens with close contact. And that's usually about maybe 6 feet away. So that's one of the preventive approaches, that we need to distance ourselves from people who do have the infection. If you're staying 6 or 7 feet away from people who are infected, you're not likely to catch the infection. Unlike other diseases that are actually extremely contagious, and just being in a room with someone who has the disease makes you likely to contract the infection.
Right. So this is one of these mitigation strategies, right? So somebody asked about one of their conferences have asked people not to shake hands. We're seeing, I guess, around the world, people are beginning to be asked to change some of their social greetings and customs, right? A smart mitigation strategy.
Yes, absolutely. Because again, if you're touching people's hands and their hands are contaminated, and your hands are contaminated, and you're touching your face, then there you have that direct contact. But if again you're keeping a fair distance from people and you're not touching anything that's contaminated, then you're not likely to contract the disease. So yes, simple mitigation measures, and at this point in time, that's our best bet. To use those, they seem very simple, but they're actually extremely effective measures to prevent contracting this disease.
Right. Another question is asking how long the virus stays on surfaces. I've seen a bunch of different data on that. What have you seen?
There has been a bunch of different data. And again, we do need to keep in mind the information we're getting. It's still an emerging condition. The information we're getting changes day to day. But generally speaking, we know that the virus can stay for at least a day on contaminated surfaces. And some reports say longer than that. But generally speaking, it's a day. It's estimated to stay whenever sputum or mucus is moist. So usually when it dries out, the virus is likely also to dry out because it does need hydration. Now, you also asked about symptomatic, asymptomatic carriers, and that's extremely important. And this is something that I really, really want to highlight in this slide. So you will see that there is a huge spectrum of illness, with some people contracting very, very mild disease and some people contracting more severe critical illness. The one important issue is asymptomatic carriers. And to date, as we mentioned earlier, we really have no way of finding out how many asymptomatic carriers are out there, what % of patients who do get infected are asymptomatic. We do know that among the cases that have been reported in China, only about 1% have been asymptomatic. But again, as Dr. Ferrero mentioned earlier, asymptomatic cases are less likely to go to present to doctors. And most of our diagnostic capabilities at this point are focused on patients and close contacts. So we're not really aiming at finding who is asymptomatic or who has the antibodies, who has contracted the infection. So do these asymptomatic cases spread the infection? Yes, there have been reports that they do. Now, based on what we know from previous viral infections, we know that asymptomatic cases tend to spread infection less. So in other words, they usually have a lower viral load. They have less virus in their body, and they usually shed less virus. So they're not as infective as people who do have the infection. And generally speaking, the more severe the case, the more the virus that's being shed, the more infective the patient is. However, there have been reports of asymptomatic cases. There have been reports of asymptomatic transmission. So that is something to keep in mind. And big question is that good news or bad news? Well, for patients, it's good news. So obviously, if you're told that you do have the virus, but you're not infected, that you're not suffering from any symptoms, then it's great news. But from a public health perspective, the existence of asymptomatic cases makes it more challenging to contain an outbreak and to limit spread. So again, the important triad that we see in this slide is fever, fatigue, cough, shortness of breath. And again, shortness of breath usually sets in later. There is a wide spectrum of disease here. Severe cases will suffer from kidney and liver insults, but most patients will have a milder form of disease. Slide, please. So this is probably one of the most important slides I will share with you today. And the question, big question is, we know that there is a huge spectrum of disease. So how many people or what percentage of patients who are diagnosed with COVID-19 actually experience critical illness? Now, as you can see from this graph, based on the early reports that we are seeing from China, approximately 80% of cases have been presenting with mild symptoms. And when we say mild symptoms, that means that the infection either hasn't caused pneumonia. Pneumonia is that very famous name for inflammation of the lung tissue itself. So either the patients have not experienced pneumonia, or they are experiencing a very mild form of pneumonia that they will very likely recover from fully. So these patients who are experiencing mild illness will have some variation of maybe fever, cough, and just that fatigue or achiness. So again, I really want to highlight this. 80% of cases will experience a mild disease.
So Heba, there's a question here about, is there evidence emerging that smokers are at increased risk of more severe outcomes?
Well, yes, there is. Now, generally speaking, most of the critical cases that have been seen, that have been diagnosed to date, have been diagnosed in patients who either are elderly or have comorbid conditions that are affecting their blood system, like maybe hypertension, cardiac conditions. And there is also evidence that in smokers, there is a higher likelihood of contracting critical illness. So yes, while this has not been fully documented, yes, there have been reports saying that smokers do tend to experience a more severe form of the disease. So as we were saying, 80% mild, 15% will experience severe disease, what we refer to as severe disease. And this is characterized by a more serious lung infection, which we were just talking about, which is pneumonia. And these are the patients that will experience shortness of breath. And again, as I was saying earlier, this is not likely to be a presenting symptom. So it's really important that we don't wait until we start seeing shortness of breath to suspect the disease. And because the infection has already reached in the lung in these 15% of people, they will also start experiencing symptoms that relate to low oxygen levels in their body, which is what we refer to as hypoxemia.
And there's a question there, Heba, then that, as to when is a patient considered critical? And I imagine it's at the point you've just said, when you begin to have real problems processing oxygen.
Yeah, well, actually, the mild cases and the severe cases, we're actually seeing them recover. The data is coming in late, obviously, because the clinical course is slower in severe patients who are experiencing this pneumonia. But critical cases are that 5% of symptomatic cases who actually do experience severe respiratory distress. And most critically ill patients, which is the question you're asking, will suffer from what we refer to as acute respiratory distress syndrome, or ARDS for short. And in some of these patients, the inflammatory reaction of the body is so severe that they also start experiencing what we refer to as a septic shock. And there's a severe drop in blood pressure. And at that point in time, multiple organs might be affected. The liver might be affected, the lungs, the kidney might be affected. And this is what we refer to as an extremely critical condition. Now, again, I really want to highlight that this only happened in China, based on the reports that we're seeing, in only 5% of cases. And we're not talking about small figures here. We're talking about maybe, as Amy mentioned earlier, we have approximately 90,000 cases now. So these figures are large. And 5% of these cases, only 5% of these cases are experiencing critical illness. Again, this is usually seen in people who are either old, very old, so quite debilitated, or they already have existing comorbid conditions, especially conditions that are already affecting the lung. For example, people who have cardiac problems, people who have, and again, among smokers. So these are the people who are experiencing the critical illness. It's important to note that among that 5%, only 2.5% of all cases, or half of that 5%, half of these critical cases may die because of these complications. Now, again, keep in mind, these figures are based on initial studies that have been reported, infections that have been counted in the worst hit areas in China. And again, as Dr. Ferrero mentioned, the total number of mild and asymptomatic cases is not known at this time. So it's very likely that as we learn more about the asymptomatic cases, that the denominator will increase, which means that we will find that it's actually less than this. So less than 5% of total infected people, less than 15% of total infected people are going to experience this severe or critical illness. Next slide, please. So how is this COVID-19, how is this disease diagnosed? Now, important to note that the clinical picture that we've described is quite typical, and that should raise suspicion. So that's the first red flag. However, definitive diagnosis does require lab testing. Now, as again, Dr. Ferrero mentioned earlier, there was a time when because of the overloaded health system, they started diagnosing it just by looking at this clinical picture and typical x-rays and typical chest CTs, but that was quickly reversed because that caused an extreme spike in the number of cases that were being counted, and it was later found to be quite inaccurate. So we do need actual definitive laboratory diagnosis in order to diagnose this for sure. So the definitive diagnosis, there are again multiple types of tests, but the most commonly used one is referred to as real-time real transcriptase polymerase chain reaction, for short, that's RT-PCR. And both the CDC and the World Health Organization have created in-house kits, RT-PCR kits, that are being used to diagnose the disease. And currently, there are also commercial RT-PCR kits that are capable of diagnosing COVID-19. Now, the World Health Organization has a list of resources and labs worldwide that do have the capability to test for this infection. But it's really important to note that not all countries have this capability. Not all countries have the same capability to test for the virus, which again is an indication that some of the figures that we might be seeing worldwide may not be as accurate as the figures that are reported, for example, in countries like the US or in countries like maybe Japan. Now, important again to note is that up until February 4th, every single sample inside the States had to be sent to the CDC for verification. But on February 4th, the FDA issued what we refer to as an emergency use authorization. And the idea was to enable the emergency use of these test kits in labs throughout the states. So now every state has labs that have been authorized or that know how to test for this virus. And in the end result, what we aim for is quicker diagnosis. And the bottom line is the quicker we can identify these cases and diagnose them, the quicker we can react appropriately, both treating vulnerable patients and in limiting infection and limiting transmission.
So Hiba, there's been a question about, well, if somebody thinks that they've been infected, when should they seek to be tested? This is a tough question because Amy talked about this earlier. Some countries are beginning to actually have kit testing where you drive up and you get tested and it becomes positive, then they'll let you go into the hospital because they don't want folks to through fear-driven, wow, I have a cough, I need to go get tested. When should somebody begin to take active measures to seek diagnosis?
That is, as you mentioned, that is a really important question. And again, it is a tough question to answer. Now, as this progresses, we're probably going to see clearer policies, but as of now, what we're being advised and what the CDC is advising everybody is, if you feel that you're infected, call your doctor ahead of time, let your doctor know, and follow their advice. It's very likely that this is going to be a case-by-case situation. So if your physician, if your doctor feels that you are a patient that may be at risk, and if the doctor is identifying your symptoms as significant enough for a test, they may ask you to come in for testing. But it's really important that you call in before you go, because we don't want the health system to be overloaded with lines of people who are waiting to get tested for conditions, and they actually don't have it. We do need to keep our resources and maintain those resources for the people who actually are going to need this. And one of the biggest fears that we have is overwhelming our healthcare system. Again, this condition is not too severe in most cases, but you don't want hospital systems overwhelmed with patients lining up to get tested. So call your physician if you feel that there's a likelihood that you may be infected and follow the guidelines that you're given. It's important that you don't wait. So if you really do feel that you're deteriorating, that you're seeing symptoms, that there's a problem, that you do reach out for help. But again, it's important that we don't panic about this. So there's a balance here. So again, the final point that I'd like to make is that serology testing or detection of antibodies is probably the best way to identify the presence of prior infection, but we're far from focusing on that at this point. Right now, we're focusing on cases and close contacts, and that's what our lab diagnostics are actually trying to identify. Next slide, please. So we've actually talked a little bit about infection. As we mentioned, it is mainly transmitted primarily via droplets, via respiratory droplets. And as we mentioned, it's mainly close contact and contact with infected surfaces. But one other problem with infection is that there's a long incubation period. And the incubation period is defined as the time between actually being infected with the virus and showing symptoms. And some diseases have shorter incubation periods, which makes it easier to diagnose patients. The longer incubation period here, which is estimated to be anywhere between 2 days and 14 days, and in just one rare report, it was as long as 24 days. But this longer incubation period is one reason why it's been quite difficult to contain and prevent the spread of this disease around the globe. So earlier on, people were traveling, and actually up until now, people were traveling and moving around when they're infected with the virus, but they haven't yet started showing symptoms. So this long incubation period is quite a challenge to public health officials. Now, the virus is pretty contagious, and as Amy mentioned earlier, the regular flu has what we refer to as a R0 of approximately 1.3, 1.4, and that is a measure of transmission that we epidemiologists use to identify the transmissibility of a contagious agent. So COVID-19 is thought to have an R0 of between 2 and 3, which means that every infected individual is likely to infect on average 2 to 3 other people. Now, some people will infect more people, and these we refer to as super spreaders, but on average, infected people will infect 2 to 3 people. Now, diseases that have an R0 of 1 will stay the same, but so long as you have an infectivity rate of anything above 1, you will continue to see this spread. Now, another important point is transmissibility and transmission inside hospital settings, and this is very important because we have been seeing nosocomial infections, which means that healthcare workers who tend to these patients and who tend to patients who are infected are even more likely to contract the infection because they're handling respiratory secretions such as saliva and mucus from infected people. And it's highly recommended that they use the proper protective equipment. And again, this is a global issue. Yes.
That brings up a very important point here. There was a question about N95 respirators and face masks and the like. Could you tell us a little bit about face masks and who should have them and when they should be deployed?
Okay. Again, a wonderful, very, very important question. Now, you might have heard about people rushing to buy face masks around the world, and this has actually been a problem. Now, as I mentioned earlier, transmission usually occurs when, or one of the most important forms of transmission is when people's contaminated hands touch their eyes, their nose, and their mouth. And what happens is when people are wearing face masks, they're likely to touch their face more. So people who are not infected by wearing face masks, they might actually be increasing their chances of contracting the infection because they're going to be touching their faces more frequently. It also gives them a false sense of security because it's been seen that the regular face masks that we use, especially for men maybe who have beards, are not as protective as people think they are. Now, the N95 masks are more protective. But again, the CDC recommendation is if you do not have the disease, if you do not have the infection, don't wear masks. You don't need them. They're not likely to protect you as much as you think they will, and they are likely to actually increase the infection. Plus, there are people who need them more than we do. So if we're going to run around and start purchasing all the masks that are available, healthcare workers and individuals who actually do need this personal protective equipment may not have access to these equipments in a timely fashion. So again, if you do not have the infection, you do not need to be wearing these masks. So who does need them? Essentially, patients who do have the infection should be wearing them to limit the spread of infection. They don't want their respiratory droplets to spread. So if you do have the infection, if you are coughing, if you are sneezing, if you do have symptoms, then yes, please wear those masks to prevent transmission to other people. You You need to prevent transmission to your family, you need to prevent transmission to close contacts, and you do need to prevent transmission to the community. If you do not have the infection, you do not need these masks, even for those health workers who really do need them. So I think next slide, we've covered most of the information on this slide. Next slide, please. So where do we stand at this point? What is being done about this? Now, the scientific community is mobilizing all its resources. There are multiple entities working on finding a vaccine and a cure. Some of these are governmental organizations, both here in the United States and abroad. There's a lot of research coming out of China. There's a lot of research coming from academic centers throughout the world. So governmental organizations, research and academic centers, and even commercial biotech companies are working diligently to find a cure or create a vaccine. Now, one biotech company based in the USA actually shipped its first batch of COVID-19 vaccine to the National Institute of Allergy and Infectious Disease, which is part of the NIH, on February 25th. And at the NIH, they are working to ready this vaccine for human testing, hopefully within the next few months. Now, this is actually excellent. This is excellent news because this vaccine was created just 42 days after the genetic sequence of the virus was released by Chinese researchers, which was around mid-January. And in my opinion, that's excellent. However, we do have to keep in mind that this still has to go through several phases of testing before it's actually ready for mass use. So at the best, we're looking at several months, maybe even longer before these vaccines are ready for actual use. There's also early data to indicate that some drugs may be effective against the virus. The focus has been on three main drugs: chloroquine, which is an anti-malarial drug, ritonavir, which is an anti-HIV medication, and remdesivir, which is an antiviral that was developed for the treatment of Ebola. There has been some evidence, some reports that these medications are effective, but again, we still have a way to go, randomized clinical trials, before we can actually start using these comfortably to treat patients. Next slide, please. So what is the current status? While there are ongoing efforts, as I mentioned, we still don't have a vaccine. The earliest estimate is that it is still several months away at best. We still don't have an effective viral cure. So what is the solution? For patients, symptomatic treatment and supportive therapy does help relieve the symptoms. Those who do experience critical illness, and as we mentioned, 5% of patients will experience critical illness. These patients will need vital organ support, and that will include supplemental oxygen, mechanical ventilation for ARDS, and if other vital organs are affected, they will need support for kidney functions, liver functions, etc. Prompt diagnosis is very important. So again, if you do feel that you have symptoms, call your PCP right away and follow the guidelines that you were given by your PCP, which is your physician. Not only is it essential to diagnose cases early because we want to control the spread, but it's also essential because the most vulnerable patients are likely to have a much better outcome if we initiate this supportive care early on. So essentially, our aim is to prevent progression to severe disease. And for those of us who are caring for elderly patients or who are caring for elderly family members, again, be aware that if these individuals do have predisposing conditions, we need to catch it early. We need to be able to provide the care they need really early on. So at this point, our best bet is to stay alert, stay informed, and my colleagues are going to talk to you a little bit more about preventive measures and ways that you can prepare and protect yourself